Chapter 9, ATI Nutrition in Enteral Nutrition. Enteral nutrition, or EN, is used when a client cannot consume adequate nutrients and calories orally but has a gastrointestinal GI system that functions at least partially. EN is contraindicated when the GI tract is non-functional, paralytic ileus, or intestinal obstruction. EN is administered when a client has a condition such as burns, trauma, or prolonged intubation, eating disorders, radiation therapy, chemotherapy, liver or renal dysfunction, infection, inflammatory bowel disease that hinders nutritional status. EN is also administered when a client has neuromuscular impairment and cannot chew or swallow food. EN feeding, or gavage feeding for an infant, is used when an infant is too weak for sucking, unable to coordinate swallowing, and lacks a gag reflex. Gavage feeding is implemented to conserve energy when an infant is attempting to breastfeed or bottle feed, but becomes fatigued, weak, or cyanotic. EN consists of a commercial formula administered by a tube into the stomach or small intestine. Enteral feedings most closely utilize the body's own digestive and metabolic routes. EN can augment an oral diet or be the sole source of nutrition. Enteral feeding routes. A client's medical status and the anticipated length of time that a tube feeding will be required determine the type of tube used. Nasoenteric tubes. So nasoenteric tubes are short-term, less than 3 to 4 weeks. Nasogastric, or NG tubes, are passed through the nose to the stomach. Nasoduodenal tubes pass from the nose through the stomach and end in the duodenum. Nasojejunal tubes pass from the nose through the stomach and into the jejunum. Nasoduodenal and nasojejunal tubes are used in clients who are at risk for aspiration or have delayed gastric emptying, or gastroparesis. For an infant, a feeding tube is inserted from the nares or mouth into the stomach. This flexible tube can remain taped in place for up to 30 days. Ostomies. Ostomies are placed for clients requiring long-term enteral feeding who are at risk for aspiration or when a nasal obstruction makes insertion through the nose impossible. An ostomy is a surgically created opening, or stoma. Ostomies can be used to deliver feedings directly into the stomach or intestines. Gastrostomy tubes are endoscopically or surgically inserted into the stomach. A percutaneous endoscopic gastrostomy, or PEG tube, is placed with the aid of an endoscope. An alternative to a PEG tube is a skin-level gastrostomy tube, which is known as a low-profile gastrostomy device. It is more comfortable, longer-lasting, and fully immersible in water. Checking for residual is more difficult with this device because of the close proximity of the button on the skin. Gastrostomy tubes feedings are generally well tolerated because the stomach chamber holds and releases feedings into a physiologic manner that promotes effective digestion. As a result, dumping syndrome is usually avoided. Jejuostomy tubes are surgically inserted into the jejunal portion of the small intestine, the jejunum. Enteral feeding formulas. Commercial products are preferred over home blended ingredients because the nutrient composition, consistency, and safety are better ensured. Standard and elemental formulas are the two primary types of enteral feeding formulas available. They are categorized by the complexity of the proteins included. Other formula types include disease-specific, COPD, kidney disease, and immunocompromised, and modular formulas that typically contain a single nutrient, protein, carbohydrates, and fats. Dang it. Standard formulas, also called polymeric or intact. These formulas are composed of whole proteins, milk, meat, eggs, or protein isolates. They require a functioning gastrointestinal tract. Most provide a 1 to 2 calorie per milliliter. Hydrolyzed formulas. These formulas are made up of nutrients that are partially or fully hydrolyzed or broken down. These formulas are used for clients who have a partially functioning gastrointestinal tract or those who have an impaired ability to digest and absorb foods, inflammatory bowel disease, liver failure, cystic fibrosis, pancreatic disorders, and short gut syndrome. Most provide 1 to 1.5 calories per milliliter. High-calorie formulas provide 1.5 to 2 calories per milliliter. Partially hydrolyzed formulas provide other nutrients in simpler forms that require little or no digestion. Packaging. Tube feedings can be packaged in cans or pre-filled bags. Pre-filled bags and administration tubing should be discarded after every 24 hours or according to facility policy, even if they are not empty. Cans can be used to add formula to a generic bag to infuse via a pump or a feeding directly from a syringe. Determining appropriate formula. Caloric density determines the volume of the formula necessary to meet the caloric needs of a client, 1.0 to 1.2 calories per milliliter. Water content and formulas with 1.1 calorie per milliliter should be 850 milliliters of water per 1 liter formula. Higher calorie formulas have lower water content. The client might need additional free water to meet hydration needs. Osmolality of the formula is determined by the number of dissolved particles of sugars, amino acids, and electrolytes. Osmolality is increased if the formula contains more digested protein. Hydrolyzed or partially hydrolyzed pre-digested formulas are higher in osmolality than standard formulas. They are also lactose-free. Fiber and residue content. Standard formulas are low in residue, which makes them less likely to produce abdominal distension or gas. These products are optimal for clients who have been on bowel rest, are post-operative following bowel surgery, or have GI-related disease processes. Hydrolyzed formulas are considered residue-free. Standard formulas that are enriched with fiber are recommended for clients who have constipation or diarrhea to normalize bowel movements. The presence of other nutrients include fats and carbohydrates, which can be modified according to a client's disease processes: respiratory disease, malabsorption, diabetes mellitus, kidney disease. Enteral feeding delivery methods. The delivery method is dependent on the type of and location of the feeding tube, type of formula administered, and the client's medical status and GI function. Excuse me. Continuous infusion method. Formula is administered at a continuous rate over a 24-hour period. Infusion pumps help ensure consistent flow rates. This method is recommended for critically ill patients because of its association with smaller residual volumes and a lower risk of aspiration and diarrhea. Some facilities require measuring gastric residual volume, or GRV, every 4 to 6 hours. Most facilities are moving away from this practice as there is insufficient evidence to support it. Feeding tubes should be flushed with at least 30 milliliters of water every 4 hours to maintain tube patency and provide hydration. Check facility policy regarding withholding feedings for high gastric residual volume, GRV. Typically, the amount is more than 250 milliliters on 2 consecutive measurements for an adult, or more than 1/4 the prescribed volume for children. Cyclic feeding. Formula is administered at a continuous rate for 8 to 20 hours, often during sleeping hours. Often used for transition from total EN to oral intake. Intermittent tube feeding. Formula is administered every 4 to 6 hours in equal portions, typically over a 30 to 60 minute time frame, usually by gravity drip or an electronic pump. Feeding times can range from 20 to 90 minutes. This is often used for non-critical clients, home tube feedings, and clients in rehabilitation. Feeding resembles normal pattern of nutrient intake. Facilities might require measurement prior to initiating the feeding and held if the amount is greater than the amount stated in facility policy or prescription. Bolus feeding, a variation of intermittent feeding using a large syringe attached to the feeding tube. The rate of administration and volume varies depending on the client's needs and tolerance. Volumes ranging from 250 to 400 milliliters can be administered over a period of at least 15 minutes, 4 to 6 times daily. Facility policies may provide further guidance regarding administration rates. The rate of administration for a premature or small infant should be no greater than 5 milliliters every 10 minutes and 10 milliliters a minute in older infants and children. Bolus feedings are delivered directly into the stomach. They are contraindicated for tubes placed into the jejunum or duodenum. They can be poorly tolerated and can cause dumping syndrome. Nursing actions. Preparation of the client. Prior to instilling enteral feeding, tube placement should be verified by radiology. The tube should then be marked with indelible ink or adhesive tape where it exits the nose and documented. Measure the tube each shift and prior to each feeding to ensure the tube has not migrated. Aspirating gastric contents and measuring pH levels are not considered reliable methods of verifying initial placement. Verify the presence of bowel sounds. To maintain feeding tube patency, it is flushed routinely with warm water. Check gastric residuals if required by the facility, typically every 4 to 6 hours in some cases. Policy or prescription will indicate whether to return the contents to the client's stomach or to hold or reduce feedings. The volume that indicates a need for intervention for adults ranges from 100 to 500 milliliters in a single measurement, or at least 250 milliliters on 2 consecutive checks. Returning residual contents to the stomach prevents electrolyte and fluid imbalance. However, returning large volumes could increase the risk for complications. The head of the bed should be elevated at least 30 degrees during feedings and for at least 30 to 60 minutes afterwards to lessen the risk of aspiration. Burp the infant following the feeding if the infant's condition allows. Begin with a small volume of full-strength formula. Increase volume in intervals as tolerated until the desired volume is achieved. Administer the feeding solution at room temperature to decrease gastrointestinal discomfort. Do not heat formulas in a microwave, as this can result in uneven temperatures within the solution. Baseline parameters. Obtain height, weight, and body mass index. Monitor blood urine nitrogen, which is BUN, albumin, hemoglobin, hematocrit, glucose, and electrolyte levels. A registered dietitian will work with the provider to evaluate nutritional and energy needs. Verify gastrointestinal function. Dysfunction of the GI tract can indicate a need for alternate forms of nutrition. Ongoing care. Monitor daily weights and INO. Obtain gastric residuals every 4 to 6 hours. Monitor electrolytes, BUN, creatinine, minerals, and CBC. Monitor the tube site for manifestations of infection or intolerance. This is pain, redness, swelling, and drainage. Monitor the character and frequency of bowel movements. When appropriate, administer medications through a feeding tube. Feeding should be stopped prior to administering medications. The tubing should be flushed with water, 15 to 30 milliliters, before and after the medication is administered, and between each medication if more than one is administered. Medication should only be dissolved in water. Liquid medications should be used when possible. For an infant or child, the volume of water to flush is 1.5 times the amount predetermined to flush an unused feeding tube of the same size. More water can be required to flush the tubing following some medications or suspensions. Interventions. Weaning occurs as oral consumption increases. Enteral feedings can be discontinued when the client consumes 2/3 of protein and calorie needs orally for 3 to 5 days. A client who is NPO will require meticulous oral care. A client can require nutritional support service at home for long-term EN. An interprofessional team comprised of nurse, dietitian, pharmacist, and the provider monitors the client's weight, electrolyte balance, and overall physical condition. Transitioning from EN to an oral diet requires the client to receive adequate nutrition as food items are reintroduced. Begin the transition process by stopping the EN for 1 hour before a meal. Slowly increase the frequency of the meals until the client is eating up to 6 small meals daily. When oral intake equals 500 to 750 calories a day, the continuous tube feeding is administered only during the night. Complications. Gastrointestinal complications. Constipation, diarrhea, cramping, pain, abdominal distension, dumping syndrome, nausea, and vomiting. Dumping syndrome occurs due to rapid emptying of the formula into the small intestine, resulting in a fluid shift. Manifestations include dizziness, rapid pulse, diaphoresis, pallor, and lightheadedness. Nursing actions. Consider a change in formula, decrease the flow rate or total volume of the infusion, increase the volume of free water if constipated, administer the EN at room temperature, take measures to prevent bacterial contamination. Mechanical complications. Tube misplacement or dislodgement, aspiration, irritation, and leakage at the insertion site, irrigation of the nose, esophagus, and mucosa, and clogging of the feeding tube. Nursing actions. Confirm tube placement prior to feedings. Elevate the head of the bed. Oh my God. Elevate the head of the bed at least 30 degrees during feedings and maintain the client in this position for approximately 60 minutes following completion of the feeding. Administer bolus feedings over a period of at least 15 minutes and according to a client tolerance. Flush the tubing with at least 30 milliliters of water every 4 hours for continuous infusion. After measuring gastric residual, before and after bolus feedings, and between each medication administration. Unclog tubing using gentle pressure with 30 to 50 milliliters warm water in a 60 milliliter piston syringe. Carbonated beverages are not approved for fixing a clogged tube. Commercially made products are available and have been shown to effectively dissolve clotted formula. Do not mix medications with formula. Metabolic complications include dehydration, hyperglycemia, electrolyte imbalances, fluid overload, refeeding syndrome, and rapid weight gain. Nursing actions. Provide adequate amounts of free water. Consider changing formula to one that is isotonic. Restrict fluids if fluid overload occurs. Monitor electrolytes, blood glucose, and weights. Monitor respiratory, cardiovascular, and neurologic status. Administer insulin per prescribed protocol for hyperglycemia. Refeeding syndrome. A potentially fatal complication that occurs when a client who is in a starvation state is started on enteral nutrition. The risk is greater with parenteral nutrition than enteral. Foodborne illness can result due to bacterial contamination of formula. The nursing actions. Prevent bacterial contamination. Wash hands before handling formula or enteral products. Clean equipment and tops of formula cans. Use closed feeding systems. Cover and label open cans with unused portions with the client's name, room number, date, and time of opening. Replace the feeding bed, administration tubing, and any equipment used to mix the formula every 24 hours. Fill generic bags with only 4 hours worth of formula. A nurse is discussing the use of a low-profile or skin-level gastronomy device with the guardian of a child who is receiving an enteral feeding. Which of the following statements should the nurse make? The device is usually comfortable for children. A nurse is teaching a client who is starting continuous feedings about the various types of enteral formulas. Which of the following should the nurse include in the teaching? Standard formula contains whole protein. A nurse is instructing a client about administering cyclic enteral feedings at home. Which of the following information should the nurse include? Setting the feeding up before you go to bed and weigh yourself daily. A nurse is preparing to administer intermittent enteral feedings to a client. Which of the following actions does the nurse plan to take? Discard feeding equipment after 24 hours, ensure that the formula is at room temperature, and flush the feeding tube every 4 hours. A nurse is administering bolus enteral feedings to a client who has malnutrition. Which of the following are appropriate nursing interventions? Verify the presence of bowel sounds, flush the feeding tube with warm water, and administer the feeding tube at room temperature.